All righty. Good evening, everyone. I'm just going to let everybody take a couple moments to join us on our webinar today. And in the meantime, what I'm going to ask everybody to do as a bit of an icebreaker is to put in the chat in your Zoom toolbar what city or town or region or wherever you're tuning in from today. My name's Troy, and I'm the Director of Operations for Nurses Specialized in Wound Ostomy and Continence Canada. And I'm tuning in from right in the heart of Ottawa, right downtown Ottawa. And I'm joined today by two phenomenal guests and who I'm going to introduce in just a second. Before we get to that, I want to remind everybody that this will be recorded today, and you will be able to watch our webinar today as a recording on our NSWOCC.ca website. For those who attend live with us today, you'll also be receiving a certificate of attendance, which will be in your inbox in the next few days here before the end of the week. We apologize for any delay in certificates over our last webinar, but we can assure you that we're back up to speed and your webinars will be coming just as they usually do. At the end of this presentation, we're going to be having a Q&A session. So if you have any questions throughout the duration of the presentation, we encourage you to put those in your Q&A button in the Zoom toolbar. That'll make it really easy for us and our panelists to be able to get to all of that at the end. So without further ado, I'm happy to introduce today's webinar, the UTI Risk Factors Model, Advancing Intermittent Catheter Nursing Practices and Patient Outcomes. And our presenters today are from Coloplast, who, again, we want to thank for being able to provide the education today. Thank you to Coloplast. So our presenters today are Carolyn Richardson, who is a registered nurse with a master's in primary health care and leadership. She recently joined Coloplast Canada Corporation as a clinical specialist for continence care. Carolyn has a practice in England and Canada as an RN, focusing on urology across acute and home care settings as a nurse specialist and nurse continence advisor. And Robin is also joining us, and Robin is the Market Access and Government Affairs Manager for Coloplast Canada. In her role, Robin collaborates with stakeholders across healthcare provider and patient communities with the goal of improving reimbursement for intermittent catheters in Canada. So without further ado, I'm happy to pass the mic over to Carolyn. Thanks, Carolyn.
Thank you very much, Troy, and everyone. Thank you for joining us today. So I would just like to start and get my, sorry, Troy, I missed some of the, here we go. That's better. It's off now. Thanks. So I'll just land the acknowledgement. Coloplast is located on Indigenous lands, and we are gathering on the land that has been inhabited by Indigenous peoples for thousands of years before us through to the current day. We recognize that these lands include Treaties 14 and 22. Oakville, as it is currently known, is the traditional territory of the Mississaugas of the Credit First Nations, Anishinaabe Nation, Huron-Wendat, and the Haudenosaunee Confederacy. These nations are the guardians of this land. We encourage you to reflect and acknowledge about the land that you are on and to understand more about reconciliation by visiting National Center for Truth and Reconciliation. Next slide. Please take a moment to read our disclaimer. Thank you. I am thrilled today to be co-presenting with my colleague, Robin Frost, as Troy mentioned, Marketing Access and Government Affairs Manager for Coloplast Canada. Next slide. So our learning objectives for today: 1, to understand the impact of UTIs on Canadian catheter users and healthcare systems. 2, to review the UTI Risk Factors Model and the effects of residual urine to bladder health. 3, to identify how Canadians' social support system impact catheter users. And 4, to explore tools to support better reimbursement for your patients. Next slide. So we can start with some definitions. So adult neurogenic lower urinary tract dysfunction or ANDLUT is the abnormal or difficult functioning of the bladder, urethra, and the prostate in men. In adults, in context of clinically confirmed relevant neurologic disorder. Uncomplicated UTI is bacteria in the bladder and associated structures in patients with no structural abnormality and no comorbidity versus every UTI in patients with ANLUT are complicated UTIs. Clean intermittent catheterization, ordinary hand and hygiene washing and the use of disposable or cleansed reusable catheters. Next slide. So what is the goal of bladder management? And so the main goal of bladder management is to protect the kidney. So prior to World War II, the primary cause of death for patients with a spinal cord injury was renal failure secondary to suboptimal management of their bladder. So when harmful pathogens make their way up to the bladder, then to the ureters and the kidneys, this can cause bladder infections, which we know as pyelonephritis. So there's a picture on the screen. You can see a normal kidney, and right next to it, you can see chronic infection or pyelonephritis. There is atrophy of the cortex, there's inflammation, and there is scarring as well. Next slide. Next slide. Thank you. I think you jumped one there. There's one missing. There we go. Lovely. So best practice in the US and Europe considers intermittent catheterization as the gold standard for treatment of neurogenic urinary tract dysfunction. And so up until recently, Canada was one of the only developed nations to recommend the reuse of intermittent catheters. And of 2020, 2 Canadian best practice recommendations on intermittent catheterization have been released to help guide clinicians to provide and to deliver better holistic patient care. And you can see there is one there, that purple with the white top, that was done by in collaboration with the NSWOCC. So well done. Next slide. So in 2018, approximately 26% of infections were resistant to drugs. By 2050, the rate of resistance is likely to grow to 40%. And UTIs are one of the most common and most resistant infection types. A 40% resistant rate in 2050 could mean the following: that 7.6 billion cost to the healthcare system, 21 billion reduction in Canada's GDP, and over 13,000 lives lost each year as a direct result of antimicrobial resistance. Next slide. So in this slide, what it's saying here is that in Canada, the average UTI treated in hospital could cost the healthcare system about $4,777. That is for one person. And the average length of stay in hospital to treat this person is 4.1 days. So as I mentioned before, by 2050, 40% of the infections are projected to be resistant to antibiotics. And next slide. UTI Risk Factors Model. So we will move right into that. Okay. So on the screen, you can see, and I'd like to say that this article, which is entitled Adult Neurogenic Lower Urinary Tract Dysfunction and Intermittent Catheterization in the Community Setting, Risk Factors for Model for Urinary Tract Infection, is an open access article by Connelly et al. So there, the problems, I'm going to start with that. is that IC users experience about 0.8 to 3.5 UTIs per year. And this is for various reasons. The authors, the methodology, they looked at literature review from the patient's perspective using the databases PubMed, Embase, and CINAHL. There was input from nurses as well and designed thinking process with 5 experts reached a consensus on each of the UTI risk factor. As clinicians, we are always looking for solutions and we are always focused on what we can do better for our patients. So the UTI risk factor model allows clinicians to consider and address the UTI risk factors for their patients. So solutions can help to identify the specific risk factors that contribute to UTIs, for example, whether it's a medical condition, hygiene practices, and much more, which we are going to look into a little bit more as we go through the presentation. It provides insight into the health benefits or the benefits for education, and education specifically as well to regarding safe IC. Patients' engagement and self-awareness about certain risk factors, and empowering the individuals as well to take proactive measures to reduce their risk of UTIs. So moving on. So I'll take some time just to run through this slide because this is it's important to know what the purpose of the review was. So one, it was the 3 main reasons to remind clinicians that the correct diagnosis and thereby treatment management of UTI bacteria contamination in the ANLOT patient population is challenging and far from simple. To update and discuss the UTI risk factors associated to IC in the community settings. And last but not least, to provide a simple, holistic, and useful risk factors model that can be used by clinicians for daily practice and thereby optimize the modification of these risk factors to the benefit of these patients. So next slide. So you can see the model has 4 main domains: intermittent catheterization, user compliance, adherence, general conditions, and local urinary tract conditions. The model intends to provide an overview of the risk factors involved with specific emphasis to describe those that in daily practice can be handled and modified by the clinicians so to come to the benefit of the individual IC user. Next slide. UTI risk factors, medical management. So on my right side would be your left, general conditions and local urinary tract conditions. We're going to look into those a little bit more. So general conditions, let's keep going. High intravesical pressure or impaired bladder compliance. And this happens because of elevated pressure in the bladder. Next slide. Sorry, yes, go ahead. Host deficiency and impaired immune system. So in spinal cord injury patients, that's damage to the autonomic nervous system, which leads to general immune dysfunction through the loss of neural innervation of the lymphoid organs. So that ability to motivate and to excite, that word innovate, this is what it means, to motivate or to incite. Okay, bowel dysfunction. So spinal cord injury patients can also be impacted with the issue of constipation, because some of the same nerves that innervate the bladder also innervate the bowel as well. Transanal irrigation system treatment has proven to reduce UTIs by 3 times. Rectal impaction contributes to urinary tract infections as well, because when the bowel is impacted, it can prohibit the bladder from working properly, and so there could be, stagnated or stale urine left in the bladder, which can cause infection. And the reflex defecation center, because it is affected because the area of the S2 to S4 innervates the rectum and external and internal sphincter as well. Let's keep going. So more on the general conditions. And age and gender can also impact UTI, but within this article, there was not a clear-cut definition for that or reason why this is so. And as we move down, we can talk about now medical management and lower urinary tract infections. And so the balance between bacterial virulence, the balance between the host and the pathogenic bacteria can cause problems as well, and antibiotics may impact the protective flora as well. Previous UTIs, so individuals with previous UTIs are more susceptible to get UTIs following any sort of issues that can impact the bladder. Botulinum toxin A injection or Botox decreases neurogenic detrusor activity as well. So Botox is injected into the detrusor muscle to try and slow down that overactivity, but it is more beneficial for patients with spinal cord injury to be treated with antibiotics because of the risk. Then there's that of urodynamic investigation. This is ordered by a urologist when an individual may have bladder problems, so leaking or overactivity of the bladder, and behavioral modification does not really work or did not work for that individual. And so urodynamic allows the clinicians and the doctors to actually see what's happening with the bladder and the urethra as well. And antibiotics should be given as a prophylactics because of the risk of UTIs after. And bladder and kidney stones can also increase overactivity. Okay, UTI risk factors. Let's look at some modifiable risk factors now, according to this article by Connolly et al. So we will look at intermittent catheterization and user compliance and adherence. So some modifiable risk factors. So what can we do as clinicians? So let's look at bacteria that's inserted by products and no, there is no urethral rinsing. Keep going. So bacteria can be introduced into the bladder with the use of intermittent catheterization. So hence the reason for a catheter that can actually diminish that risk or mitigate that risk as much as possible. So positive influence on catheter design should be something we should be looking at is that of hydrophilic catheters for performing clean, intermittent bladder management, because it's less steps in actually preparing a gel, a catheter that needs lubrication, and then to be inserted into the bladder. Whereas hydrophilic catheters are already coated catheters, and so it reduces the risk of infections. So compared to gel lubrication catheters, with hydrophilic coated catheters, there's less urethral trauma, so less hematuria, less removal friction, and less pain for the individual. And given the knowing that an individual who catheterizes should be catheterizing between 4 and 6 times in a day, that could truly help reduce problems with the fragile urethra. The hypoosmolar coating increases water content on the hydrophilic catheter coating, reduces both removal friction and urethral trauma during catheterization. In difficult and traumatic catheterizations linked to urethral trauma and false passages, which are associated with urinary tract infections and strictures as well. And so, education about the proper use of hydrophilic catheter is key for a lot of IC users. Let's keep going. And again, so we talked about all this. So hydrophilic catheter is recommended to reduce urethral trauma. And now we come to post-void residual urine due to product design. And so proper length with proper placement of the eyelets, considering catheter stiffness and catheter handling. These are all important features that should be taught to an individual who will be engaging in IC every day and multiple times per day. User compliance and adherence. So avoiding frequency, in this article, what was brought out is that it's important to keep catheterized volumes under 4,000 milliliters. So infrequent voiding, emptying can stretch the bladder. So when an individual is not emptying according to the prescribed regime, or at least 4 times a day, the bladder can be stretched to hold a large amount of urine, and then the bladder is not emptying properly, so there is a risk of urinary tract infections as well. Fluid intake. And fluid intake is very important for everyone, including patients with neurogenic bladder. So poor fluid intake is a risk of, it puts an individual at risk of developing UTIs. And we all know that we can tell when someone is not drinking well. They have dark concentrated urine, and urine should be pale yellow in color. And so we know that they're not drinking enough if the urine is dark. And some people will tell you quite plainly they don't drink because they don't like water. It's tasteless, and they prefer to drink maybe coffee. I have met people in my practice, a gentleman who he drank 8 cups of hot chocolate every day, and that was his total fluid intake. Some people, it's coffee. And coffee has caffeine. It's a diuretic. What it does, it tells the kidneys to produce lots more urine. And so if the bladder is not competent as it should be, then what happens is that there's a possibility of, getting infections. On the other hand, low fluid intake, it's not good as well. It increases acidity, and this may predispose an individual to UTIs as well. There's variations in the antidiuretic hormone in individuals with spinal cord injury, and they need to drink more fluid. So at least 8 glasses. And so at night, because of the reduction in antidiuretic hormone, um, these patients, they need to also, so they create lots of urine at night, and so polyuria. So these people need to actually space out the fluid intake as well, and drink most of the fluids during the day and less at least 2 to 3 hours before bedtime. Drinking enough water, enough fluids help to dilute the urine as well, and it prevents recurrent cystitis in premenopausal women. Next slide. So there's also non-hygienic procedures. So genital and perineal cleaning is associated with reduced UTIs. The no-touch technique procedure when it comes to catheterization is recommended as well. It's important to wash hands with soap and water before one catheterizes themselves. A lot of people think it's best that they go to the toilet, and after using the toilet, that's the time they're supposed to wash their hands. But if hand washing it does not occur prior to going to the toilet, what happens if your hands are dirty and they're touching, catheters and getting the lube ready and things like that, and it's not a hydrophilic catheter, then that's a problem. They can transfer bacteria from the hands into the catheter and ultimately get urinary tract infections. And so also wiping from front to back is important to teach individual as well, to prevent the spread of bacteria and reduce urinary tract infections. Vulvovaginal symptoms can increase UTI. So vaginal infections such as yeast infection, vaginitis, which can also alter the vaginal flora, and urethral irritations from inflammation. And for some individuals, every time after sexual activity, they would get a urinary tract infection. So these are things that that one should be taught and and shown actually what they should do, because sometimes we take it for granted that people know how to wash their hands properly, how to wash the peri area properly, and the truth and the fact is that they really don't. They need us to really teach them. And so insufficient education is a big problem. So education regarding IC technique is key. And the benefits are reduced bacteria, urea, reduce UTIs, and reduce antibiotic treatment episodes for these patients as well. User compliance adherence, so post-void residual due to incorrect handling of the catheter. There are many causes for post-void residual, so urine that remains in the bladder and it's not emptied. Removing the catheter too soon or too early could lead to UTIs as well. And correct procedures should be included when training these patients. As a matter of fact, when a patient presents to a clinician with urinary tract infection and they have spinal cord injury or neurogenic bladder, and they have UTIs, this is a good time for clinicians to actually take the opportunity to see how they self-care and if they're doing it properly or not. And this is a time to also provide education. Individuals, women with pelvic organ prolapse as well, can also hinder bladder emptying. And pelvic organ prolapse among women, including those with spinal cord injury, female with spinal cord injury, is very common. And so some people will have to sort of move the prolapse aside in order to self-cat. So their hands again need to be clean, the peri area need to be clean as well, and to avoid problems and so that they can empty their bladder properly. Okay. And so last but not least here, some people have, you can see the bladder shape there. It's like a cone or Christmas tree sort of shape. So post-void residual of more than 100 mils is a risk for neurogenic population. This population may have problems emptying their bladder. And so the anatomy may limit emptying and causes high PVR. So lack of education on catheter handling, product and anatomical and bladder abnormalities should be taught. And then there is the issue of detrusor hyperexia, and that is also known as overactive bladder. This is when the muscle is responsible for pushing. This is a muscle that's responsible for pushing the urine out of the bladder, so that detrusor muscle when we're voiding. So in individuals with detrusor hyperflexia, these contractions occur without the individual's control or desire to urinate. So it's important that we know exactly what's happening with our patients so that we can better address the issues and provide some tips and tricks and so that they can empty their bladder more effectually and have a better quality of life. Next slide. Yes. And here's where I'm going to call on my colleague, Robin, to take over here to continue.
Robin? Hi there. Sorry, I'm trying to turn my camera on. It doesn't seem to want to. Oh, there we go. Cooperate.
Okay.
Hi, everyone. Thank you. And thank you, Carolyn, for walking us through the model. My name's Robin. As Troy and Carolyn were so kind to introduce me, I'm the Market Access and Government Affairs Manager for Coloplast Canada. And I'm here really to talk about the idea and the impact of social support systems. So one of the modifiable risk factors in the UTI Risk Factor Model is this residence country and social support system, which can mean reimbursement. Looking at a global scale, there are definite differences in care across various countries. These can be dependent on the development of a nation versus another nation, and then within a country can be dependent on socioeconomic status, resources within the area, geographical landscape, and access to care nearby the home. In countries where we see that clean intermittent catheterization is a well-established standard of care, we see lower UTI rates, and then higher UTI rates, not surprisingly, in countries where it is not as established. Next slide, please. So I think it's important that when we're talking about UTIs and this risk factors model in a Canadian context, we need to acknowledge a very real challenge for Canadian catheter users, which again was identified as one of the risk factors in this model, the residence country and social support system. Next slide. And next slide again. So as many of you likely know, coverage or reimbursement for intermittent catheters in Canada is far from optimal. But many are actually surprised to learn, many Canadians are surprised to learn that this is not the case in many other countries. The unfortunate reality is that Canada is an outlier when it comes to catheter coverage on a global scale. We are one of the only developed nations in the world that does not provide, at minimum, coverage for single-use catheters. Most countries that Canada would compare itself to as a peer nation, so most of Europe, the United States, the UK, they all provide coverage for single-use hydrophilic catheters as well. In Canada, catheter coverage is patchwork and piecemeal at best. Where there are provincial programs, most of them are means tested, which means that they're only available to those below a set income threshold as part of a social assistance program, what would kind of commonly be termed welfare. The only two provinces that provide significant coverage that is not means tested or heavily means tested are Saskatchewan through their Saskatchewan Aids to Independent Living Paraplegia program. There's fantastic coverage through this program, but it is limited to a very set patient population. And then in Alberta, we have the Alberta Aids to Daily Living program, which provides pretty good coverage as well. And this is open to most Albertans. There is also pretty decent catheter coverage for those who qualify for the non-insured health benefits program and veterans assistance at a federal level. But all that to say, this still leaves the majority of Canadian catheter users with either partial or no coverage for their catheters. Next slide. So the lack of coverage for catheters in Canada means that many users are forced to make a really hard decision around their catheter routine, often with potential impacts to their bladder health. Users who can't access enough catheters to accommodate a single-use routine may opt, and Carolyn touched on this earlier, to either reuse their catheters or to reduce their fluid intake and voiding frequency and skip catheterizations, or often both. They will skip catheterizations, increase their voiding or reduce their voiding frequency, and then catheterize with a reused catheter. Last year, Coloplast actually ran a survey among catheter users in Canada to better understand the impact that catheter funding has on users in Canada. We had almost 600 users complete the survey, and as you can see on the slide here, the results tell a pretty compelling story. So 1/3 of users indicated that they reuse their catheters, and those that reuse, the majority reuse 5 or more times. And I have to tell you, many of those indicated that they reuse a catheter 10, 20 or more times. A recent publication just earlier this year looked at the impact of short-term catheter reuse just over 3 days. And even with that short-term reuse, the results found catheter surface damage, debris, biofilm deposits, and bacterial colonization, again, occurring just within that short-term reuse. So those who are reusing even longer are just putting themselves at increased risk. Last year, Coloplast also surveyed clinicians, looking at the unmet needs of catheter users in Canada from a healthcare professional perspective. And shockingly or not shockingly, Canadian HCPs perceived that the ability to afford and access catheters was the biggest challenge that Canadian catheter users face. And catheter users can face some pretty big challenges when it comes to some of the clinical impacts and possible challenges that come along with UTIs, with urethral trauma, with any of the complications, as well as some of the mental and social challenges that being a catheter user can carry. But all this aside, clinicians still felt that the ability to afford and access catheters was the #1 challenge. The majority of clinicians also indicated that catheter reuse was taught in their facilities. And importantly, that if they did not know that funding was a challenge, that they would not teach patients how to reuse their catheters. There is no clinically validated and universally accepted safe way to wash and reuse a catheter. So many people are out here, users are out here kind of just winging it and doing the best they can. And unfortunately, healthcare providers are well aware that the reality is that some people will have no other choice than to reuse their catheters. So they have to support them as best as they're able. Importantly, also, this lack of coverage means that many users cannot access hydrophilic catheters, which, as Carolyn spoke about earlier, are really the gold standard for intermittent catheter users and for bladder management in general, especially in the neurological lower urinary tract dysfunction patient population. Next slide. So there is some good news here, which is that we are beginning to see some changes in this space. We've seen both clinicians, healthcare professionals, and patient organizations become more vocal in the last couple of years in their advocacy for a better standard of care for catheter users in Canada. So Carolyn mentioned earlier, in 2020, we had the best practice recommendations from a collaboration of nursing groups, including NSWOCC. And the same year, we also had a best practice report from the Canadian Urological Association, both of which recommended single-use pre-lubricated hydrophilic catheters as the standard of care, as the first-line treatment. This was a really huge milestone. as we finally had published recommendations to support single-use in Canada. And more importantly, the nursing recommendations stated that they no longer supported the reuse of catheters in Canada. These recommendations were really a game changer because they gave patient organizations a proverbial leg to stand on when it came to their advocacy. So they could finally point to the fact that the coverage in their provinces did not provide users with the ability to follow best practice. Some of these patient groups, along with some healthcare professionals, have been able to engage in dialogue with provincial governments, most notably in Ontario and Alberta, and engage in a dialogue on how to fill this unmet need. And really excitingly, in Alberta, AADL over the last 2 years has made some really significant improvements to its catheter coverage, moving from essentially 1 uncoated catheter a day to now providing 4 catheters a day and including hydrophilic options. So this has been a huge win for catheter users in Alberta. Next slide. Coloplast Canada is really committed to being part of this change and to raising the standard of care for catheter users in Canada. We do this both by helping users find and maximize the existing reimbursement options that are out there, but also by working to create or expand new coverage, either through provincial or federal programs. We've been very invested in supporting research and publications that help illustrate the need for single-use hydrophilic catheters, as well as to prove the benefits of single-use coverage to both users and to the healthcare system. We were incredibly proud to support the writing of the nursing best practice recommendations for urethral catheterization in adults, and equally as proud to support and collaborate with patient organizations across the country, both to support their services and their advocacy effort. And then finally, my role here at Coloplast Canada of Market Access and Government Affairs Manager was created in 2020 as a dedicated resource to collaborate with both healthcare professionals, with patient organizations, and government stakeholders to with the goal of creating or improving catheter funding. Next slide. So as I mentioned, change is happening, but the reality with this kind of work is that change takes time. In the meantime, Coloplast does have some tools to help users and healthcare professionals navigate the coverage that is out there at the moment. So our Coloplast care team is a great resource. They're very well versed in the catheter coverage options in each province, and they're able to walk patients and users through kind of a validation process to see what program they might be eligible for. We many times have spoken to catheter users who qualify for a program but don't realize it or don't even know it's out there. So this has been a great resource. Our letter of recommendation is a really great tool. It acts as almost like a prescription by providing a clinical rationale as to why a user needs to use intermittent catheters. It gives an opportunity for the healthcare provider to select a specific catheter and prescribe a frequency of catheterizations per day. We've seen this very successfully used to support claims with private insurers, provincial and federal programs as well. And finally, most recently, we have our catheter coverage website, and we'll provide a link to this at the end. But this is a really great resource, both for catheter users, for patients, and for healthcare professionals as well. All you need to know to start off, or all a user would need to know, is what province they live in. So everybody knows that. And from there, from selecting your province, it will give you a detailed rundown of all of the possible programs for catheter coverage that are available in your province. And it covers provincial programs, federal programs, some kind of tips and tricks for navigating private insurance, as well as a few municipal programs as well. So it's very user-friendly and a really great resource for both patients, users, and healthcare professionals as well. Next slide. So to wrap up, the key messages that we hope that you'll take away with you today. UTIs are a significant issue for Canadian catheter users and the healthcare system. The UTI Risk Factors Model provides a simple, holistic, and useful risk factors model that can be used by the clinician for daily practice and thereby optimize the modification of these risk factors to the benefit of the patients. Catheter-associated urinary tract infections are prevalent in the neurogenic lower urinary tract dysfunction population. Compliance and adherence to the prescribed catheterization schedule are key factors in preventing UTIs. And catheter reimbursement in Canada leaves many users reusing catheters or reducing their voiding frequency. And finally, as I mentioned before, and I believe we will be sending this out as a follow-up document as well. I see the font's a little bit messed up there, but you can screenshot these if you like. The code on the left, it will link directly to our Coloplast Care program and team, and the code on the right will link directly to those reimbursement web pages that I spoke of a few minutes ago. Next slide. I think that's it. I think it's time for Q&A with Troy.
Well, what I'll do here, I'll leave this up just in case people want to take a couple extra seconds to get access to it. First, I'll just say thank you so much to both of you for a fantastic presentation. I can tell by the questions we've got coming in here that people really appreciated and enjoyed this. I think we got about 13 minutes here, so we might just jump right into this here. The first question I have, we kind of work back to front here, I guess. The first kind of questions are talking about the products themselves here. If I can maybe just throw this over to you, Robin. Are you aware of any type of catheter containers potentially that patients can use for their intermittent catheters? Is this something that you either you or Carolyn have come up before, a certain type of system to hold the catheters?
I've certainly seen some on the market. I mean, Coloplast doesn't make any, and I don't know that any of the catheter manufacturers that are on the market in Canada make anything specific. And it's certainly easier on the female side because they're a little bit more compact. But I've certainly seen people using kind of a longer, smaller kind of canvas bag to hold their catheters. Many people obviously just put them in their backpack or whatever. And that's where some of the compact catheters come in really handy, especially again on the female side, being able to throw them in a purse or even a pocket in some cases as well. But whether or not there's something specifically on the market to hold catheters, either in the house or kind of when you're out and about, not that I know of, to be honest with you.
No problem. Well, maybe we'll come back to something like that a little bit after. I'm going to kind of combine two of these questions, and I'll open up to either you or to Carolyn there. We had two questions about the rate of UTIs for those who are using hydrophilic catheters versus not using those. Do we know any of that data by any chance? Or even if you could speak, maybe Carolyn, too, from your practice as well. Do we know about the rate increase for UTIs for those who might be using hydrophilic versus non-hydrophilic catheters?
So I can actually speak to this, even though I'm not a clinician or a nurse by background, but only because I was doing some research earlier today. But in a 2018 paper, which was actually a health economic analysis, but looked at the benefits of hydrophilic catheters versus uncoated catheters. And I believe the lifetime rate in UTI reduction was 13%, I want to say 12 or 13% over a lifetime horizon.
Gotcha. Well, thank you for touching on that. And I think that covers both yours and Shelley's. And I see Shelley asking the question here reminds me of our last journal club we had just a couple of weeks ago was on our continence topic and specifically on the role of D-mannose. And I think this bleeds well into Tammy's question here, who's asking about the role of cranberry juice or cranberry capsules with D-mannose being that active or that the sugar in there. Do you know of any proof that this actually helps prevent UTIs? Is this something that is still typically recommended? How do we approach the relationship of cranberry juice or cranberry capsules to UTI prevention?
Yeah, so it's a good question. There's certainly some evidence to show that cranberry pills, not so much the juice, because I think the juice, it has been said, is that the juice is too acidic for the bladder. And so the cranberry pills is what we would recommend when I worked at the pelvic floor clinic back in Calgary. And this was regularly recommended. However, if the patient is on Coumadin or some sort of blood thinners, it's not recommended because it interacts. And so the patients would not get the full benefits of it. But certainly cranberry pills does seem to have some efficacy in warding off urinary tract infections in people who get frequent urinary tract infections. That alongside drinking enough fluid. I can't stress how much it's important to drink adequate amount of fluid every day, and the right type of fluid, so mainly water.
Perfect.
Hope
Okay,
that
well, thank
answers
you
your
for,
question.
yes, that is perfect. And it was a big topic of discussion a couple of weeks ago, so I'm glad someone was bringing up that question as well. I have a couple more questions here for you, Carolyn. This one is from Joanne. I think you might have touched on this briefly at the beginning, but let's go over this here. If a person tends to hold on to their urine too long, does this tend to contribute to increased rates of UTIs or even kidney damage?
Yes, definitely. And holding on, I've had patients tell me, oh, Carolyn, this is when I lived back in Alberta. Carolyn, I could hold my urine from Calgary to drive to BC. And you know how many hours that is. And what it does, it's you stretch the bladder to hold too much urine. And so you damage the nerves in the bladder. And for spinal cord injury patients, the nerve damage is already there. For patients with diabetes, nerve damage is there as well. And so drinking enough, too much water or holding on to your urine past 4 hours is not recommended. It's not good practice. We should empty our bladders. A good working bladder, we should go to the toilet between 4 and 6 times, at least 6 times in 24 hours. So holding on to the urine and stretching the bladder is not good practice.
Absolutely. And I know we have talked, I think, in another Coloplast webinar about the social factors sometimes that go into holding the urine as well. But I think it's an important question. So thank you for bringing that up. Another question we have here, and this was going back to the unfortunate scenario where sometimes, because we are seeing reusing the catheters, it's now being taught as well to make sure you can do it as safely as possible. What Darren asked, what are some of the common practices of resanitizing by the user when the catheter is reused?
So it's first of all, I want to say Health Canada does not approve reuse of catheters. Some people are doing all sorts of unscripted practice. Some still put it in a microwave. Some are using soap and water, or some are using vinegar together with water, and they are to clean the urine. Yes, actually some people are using bleach, and that is not recommended. So to reduce urinary tract infections, single-use catheter is the gold standard. Hydrophilic catheter is best used. That's also known as the gold standard. And recommendation for reusing catheters is not recommended at all.
No problem. Well, thank you for mentioning that there. And on the same topic, I guess, of the hydrophilic catheters here, Laura's asking what the environmental impact of hydrophilic catheters are. And I know we've had this topic come up at other presentations in the past too, but did you want to comment on that to Laura's question here?
Yes. Unfortunately, we don't have a biodegradable catheter. There's none out there at the moment. And so what we have is what we know, what we use. So to really say it's a significant impact on the environment, that's definitely a debatable topic. But as far as now, there is no biodegradable catheter. So we do what we can, and we use what is best so that our patients can have better quality of life. And the hydrophilic catheter is really one that allows them to have that and enjoy that quality of life with less urinary tract infections, less hospital costs as well, and yes, it's something that we would like to see in the future. But maybe it's to come. Yeah. Who knows?
Exactly. I think that's what we're all hoping for.
Carolyn makes. Yeah. Sorry, Troy. It's a good point that Carolyn makes, is that when you think of environmental impact, it's important to really zoom out and look at the whole holistic picture. Yeah. And as Carolyn mentioned, take into the account the impact that UTIs, repeated UTIs, hospital admissions and hospital stays, both environmentally and in terms of antimicrobial resistance as well. As an industry, as Carolyn mentioned, there are no biodegradable or recyclable catheters as of yet. And I know that's something that as an industry is being worked on, but it's a huge project and it has to involve the plastics industries and there are so many players that need to come together and that are working to come together to make some progress in this space. But as with everything, it takes time.
For sure.
Absolutely. I'm going to ask a question here, maybe this, well, to both of you, but maybe to Robin specifically here. We've had quite a few questions coming up about the difference in price for catheters, either across Canada or the difference in price between our hydrophilic and our non-hydrophilic catheters. Would you be able to touch on maybe a little bit of that? I know you've got the funding background as well. Is there any sort of consensus for a standard price across Canada, or what are you seeing?
I wouldn't say there's consensus for a standard price, and I think the reality is that intermittent catheters in Canada are expensive across the whole market. And in fact, if you kind of look unit for unit, dollar for dollar across globally, intermittent catheters are more expensive in Canada than they are most elsewhere in the world, certainly where there's coverage. It's kind of a chicken and an egg situation, but the reality of it is that this is because of the lack of coverage. So in markets where reimbursement was already in place or was secured like very soon as intermittent catheters and especially hydrophilics were introduced to the market, they were priced to meet whatever the reimbursement maximum was. So that natural cap was there already. In markets like Canada, where there was no reimbursement, there was no maximum price, and the only kind of guiding light, I guess, or the only kind of guide in pricing was the maximum of whatever private payers would pay, which at the time in Canada was pretty high. Certainly Coloplast, as reimbursement is opening up and as pockets become available, we are working within those provinces, as an example in Alberta, to work with our retail partners to make sure that Coloplast products at the very least are available to users at the reimbursed price, even if it's kind of below our market price. We're working to make sure that users are able to access it through the reimbursement that is out there.
Perfect, and thank you for touching on that. And I know we're getting close to our end there, but we have one more question here from Heidi, who's asking, do you foresee the use of single-use catheters in long-term care settings? And do you know of any funding that exists for this across Canada?
I can't speak to practice in terms of what's happening in long-term care settings. It's just simply, it's not my wheelhouse, to be frank. In terms of funding, there would be the same funding in whichever provinces there are that have a provincial program that kind of falls under that social assistance kind of category, would apply in most cases to people over 65. But then the interplay between whatever contract exists within the long-term care setting would factor into that as well. So it's difficult for me to say province by province. Carolyn, I'm not sure if there's anything that you can add in terms of the practice and the prevalence of using catheters within the long-term care setting.
Yeah. I think currently across Canada, there are instances where in long-term care, patients are still using and reusing catheters. They may have, what I've seen from mostly is they may open a new catheter in the morning, and that catheter will last for the rest of the day. They will wash and rinse, and they would use it for emptying for the entire day, 24 hours. And then the following day, they open a new. So each day they would use a new catheter. And that's a common practice across long-term care in Ontario.
Fantastic. Well, I see we're at our time here, so I just want to thank both of you, and again, Coloplast, for being able to bring us this education from the risk factors model all the way to where Canada stands globally. I think it's a lot of really good information and very interesting to see this issue discussed. I can tell from all the comments here just how much everybody has appreciated this. I see Linda saying, thank you so much for this information. Very informative. Thank you. Lots of clapping hands, emojis in the chat too. So we really hope to have you two on again in the future. And I know that we'll continue our partnership with Coloplast going forward as well. So I'm just going to remind everybody here that this has been recorded. You can go watch this again after. If you have a colleague who you want to recommend it to, you're absolutely welcome to do so. I believe we will be having a follow-up email either from NSWOCC or from Coloplast, so I know you'll be getting some information that way as well. Do make sure to complete your survey at the end of this webinar. It's going to pop up in your browser once we're done. And we look forward to seeing you at our next webinar. Thank you again, Carolyn. Thank you again, Robin. We look forward to seeing you again soon.
Thank you. And thank you for your input and your support.
Absolutely.
Much appreciated.
Good night, everyone.
Good night.
Good night.
Thanks, Robin. Thank you.